COVID-19 is a novel viral disease that led to the pandemic in 2019 and throughout 2020. It is believed the virus infects the lungs through the angiotensin-converting enzyme receptor. This process may also occur in the kidneys. It appears the incidence of acute kidney injuries in patients infected with COVID-19 parallels with the severity of the disease, and having an AKI increases your mortality. These AKIs are multifactorial. Additionally, the shock secondary to COVID-19 and its management can also lead to derangements in the kidney, such as free water balance. In this case, we present a 25-year-old with prediabetes who presented in hypoxic respiratory failure secondary to COVID-19 with an AKI and developed transient diabetes insipidus and panhypopituitarism. On presentation, the patient was hemodynamically unstable and required intubation and multiple vasopressors, including vasopressin. He tested positive for COVID-19 virus. On day 1, the patient had an AKI with a creatinine of 4.27 and a BUN of 25. His sodium on presentation was 130. Urinalysis demonstrated glucosuria and large blood. His creatinine downtrended with fluid resuscitation. On day 2, his 24-hour urine output was 9.9 liters. This was managed with isotonic fluid replacement. His serum sodium was still 130, urine sodium 141, and urine osmolality 364. Vasopressin was increased and subsequently urine output decreased. Stress steroids were initiated. On day 3, his urine osmolality increased further to 768, and his urine sodium was 150. On day 4, vasopressin was discontinued and urine outputs increased substantially. Serum sodium jumped from 129 to 137, and urine osmolarity decreased from 768 to 111. CT head showed partial empty sella, and endocrine labs demonstrated panhypopituitarism. He was started on levothyroxine, continued on steroids, and received multiple DD-AVP doses and free water correction. Unfortunately, his condition worsened and care was eventually withdrawn. This patient's kidney dysfunction is multifactorial, including direct injury, cytokine storm, ACE pathway, complement dysregulation, hypercoagulable state, and myoglobin toxicity. His presenting AKI likely demonstrates proximal tubular injury due to glucosuria and low BUN to creatinine ratio. Autopsies of COVID-19 patients found extensive proximal tubule dysfunction, which leads to a lack of reabsorption of solutes, resulting in solute diuresis. The patient went on to develop transient diabetes insipidus following stress-dose steroids and panhypopituitarism. It is unclear if the patient experienced primary empty stella due to a hole in the sella diaphragm or secondary empty stella syndrome due to pituitary gland damage from his hemodynamic instability. The most common cause of secondary hypopituitarism is pituitary apoplexy due to infarction from an adenoma, surgery, or hypovolemia during septic shock. Typically, patients present with deficiencies in TSH, LH, and FSH, like our patient. Involvement of the posterior pituitary is less common than the anterior due to the infundibular process of the neurohypophysis having dual blood supply, protecting it from ischemia. Damage to the posterior pituitary can lead to transient polyuria, for ADH is still produced in the hypothalamus and enters the circulation through the portal capillary in the median eminence. Diabetes insipidus is a disorder of water homeostasis leading to large volumes of hypotonic urine. In panhypopituitarism, diabetes insipidus may not initially present clinically, for a steroid deficiency impairs free water excretion, and it is only when this cortisol deficiency is treated that the polyuria is unmasked. Our patient may have had panhypopituitarism prior to presentation, and it was only unmasked when the patient was provided pulse steroids due to his critical illness. Or he may have developed acute pituitary ischemia due to hemodynamic instability secondary to COVID-19, leading to diabetes insipidus. Overall, renal impairment in COVID-19 infection significantly worsens a patient's mortality. COVID-19 is known to damage the proximal tubules, leading to AKI and resulting solute diuresis. The hemodynamic instability that results from an extreme inflammatory response can lead to end organ damage, including the pituitary. While the posterior pituitary is typically protected due to the dual blood supply, infarction of the stalk can lead to transient or permanent diabetes insipidus. Patients with primary hypopituitarism may not demonstrate clinical signs of diabetes insipidus due to steroid deficiency.